Good afternoon. I am presenting a very interesting yet challenging case of donor-related multidrug resistant Klebsiella causing interface keratitis and lamellar keratoplasty. So this is a case of 17-year-old boy who was diagnosed with keratoconus left more than right eye, and his BCVA was 6.9 in the right eye and 4/60 in left eye, which was not improving due to presence of apical scarring. And thinnest pachymetry in right eye was 438 and left eye was 321 microns. So we planned C3R in the right eye and deep anterior lamellar keratoplasty in the left eye. So the surgery went uneventful under peribulbar anesthesia, and we used donor tissue from 65-year-old, and it was retrieved from hospital, and in situ corneal excision was there, stored in cornisol, and donor death to transplantation time was 5 days. So on day 1, post-operative day 1, patient had mild pain, conjunctival mucopurulent discharge and ciliary congestion. And we could see multiple yellow-white deposits at graft-host interface, and which was further confirmed on ASOCT. And keeping both bacterial and fungal in mind, we started fortified antibiotics and antifungals, and we planned for the regraft as well as collection of samples for microbiological examination on the same day. So since the exudates were extending beyond the graft host junction and we didn't have very good quality of cornea with us, so we planned for penetrating keratoplasty, not going for regraft, lamellar graft, and we oversized the graft by 0.5 millimeter. And all samples removed lamellar graft, host, descemet membrane, corneal scrapings taken from the stromal blood, as well as the residual corneoscleral rim with storage media, all were sent for microbiological examination. So on very next post-operative day, we found that infiltrate and stromal infiltrate as well as hypopion reappeared again, and they were kept on progressing. And smear showed gram-negative bacilli, culture and sensitivity reports were still awaited. So we started topical vancomycin, ceftazidime, as well as oral corticosteroids. So after 48 hours, all sample which were sent for the culture revealed Klebsiella pneumoniae, and the Klebsiella was also positive in donor corneoscleral rim. So it confirmed the donor-host transmission of infection. Unfortunate part was this organism was multidrug resistant and only sensitive to colistin. So we started colistin drops early and along with oral and topical steroids. So on the next day, after 48 hours, we got a very good quality optical tissue with 3022 cells per cubic millimeter. So we again posted the patient for a keratoplasty with the anterior chamber wash with the colistin. And now patient has completed around 4 to 5 months. We continued colistin for 6 weeks and then stopped. And now he has no recurrence of any infection and attained 6/9 vision with minus 1.5 diopter cylinders. So post keratoplasty microbial keratitis is not an uncommon entity. Its incidence is around 6.5% to 10.5%, and most common organism isolated are fungal, basically candida, followed by gram-negative and gram-positive organisms, and most of them are related to donor. So the common risk factors for having this donor host contamination is multiple warming cycles. In lamellar keratoplasty is common because there is a potential space for growth of microorganism, and long-term hospitalization, and the patients who were treated with multiple antibiotics, who have ICU stay for more than 4 days, and death caused by the sepsis. And in DALC, again, it gives a good space for the growth of organism, and there is organism are actually protected from the direct exposure to antibiotics. So these cases are really challenging to treat, and there are 4 cases reported of Klebsiella pneumoniae in day 1. And all showed that all had a very acute onset either on day 1 or 2, and all were managed with the immediate intervention, surgical intervention in form of lamellar keratoplasty or penetrating keratoplasty with recognition of organism, and sensitivity of drugs are very important to deal with these organisms. So targeted antimicrobial therapy and consideration of early surgical intervention are required to treat these cases of infectious lamellar keratoplasty, particularly after DALC.